There was a huge, all these wrecks on 25. And
It's a little busy too.
There's always traffic at 104th too, every morning, for
right.
whatever reason. That's always
Yeah, and I come
bad
down
spot.
Federal to I-36, I don't even go across 104th, I just skip that all.
We're on
Yeah.
film, guys.
All
We're on
right.
film. My submission to the Sundance Film Festival is going to get ruined here. All
We
right,
have to change something up, this is not working.
Yeah. So I wanted to go through this in-service, or create this in-service and provide it because I think we all have gotten the feedback at one point or another that we need to be accurately rating the Oasis questions because they're pretty important. And I think a lot of the times the feedback that gets handed out or gets passed down is that we need to be rating patients lower so that we can have some room to improve, which on some level is true, but ultimately the focus shouldn't be on trying to rate them lower so we can show improvement. The focus should be on rating them accurately so that we can capture the improvement that that we're helping them achieve. And when you read through the guidance manual, which for the record this in-service is pretty much pulled directly from the Oasis C2 manual, you just kind of start to see that the descriptions that were given in these questions are really it just seems to be a disconnect between how the questions are written and what they actually expect us to take into consideration when we're rating the questions. So that's really what I wanted to delve into, is to really clarify that it's not that we should be rating people lower, but we are probably not rating them low enough based off of what the expectation is. So I'm going to gloss through some of these first few slides that give a brief overview of what Oasis is, because I think most of us have a good understanding of that, and Claudia does a lot of education on that. But basically, Oasis is an outcome measure. It stands for Outcome and Assessment Information Set. It includes data collection on 100 different items on the start of care assessment, and all of these questions are interspersed throughout these sections here listed in the next slide there: patient tracking, clinical record. All those sections have some of these Oasis questions embedded in them. Anytime you see an M in front of in front of a number, that's an Oasis question. And it serves for CMS to be able to track patient outcomes at 2 points in time. It's also used to calculate the payment algorithms we get through the Medicare Prospective payment system. Not every single question goes into that, but there's I think 25 that go into some beep boop 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 little algorithm, and then spits out a case mix model for us that determines how it paid. So it's not just that we need to be able to show improvement, but it's also important that we're rating it correctly so we can get paid correctly. Next two slides, I mean, this is just more of a description of what Oasis is used for: quality reporting. CMS wants us to have a way that we can show how good we're doing. So as much as this may be a frustrating thing, it's really a way for us to be able to, take credit for the good work that we do. And then I do think it's interesting, again, as far as the prospective payment system, I won't go into a ton of detail, but there's 153 case mix models or home health resource groups, or if you hear the phrase HERG score or HERG classification, that's the payment model that a patient falls into. And from this line here on the bottom of this slide, on the prospective payment system slide, that says inaccurate Oasis data may result in inappropriate reimbursement to your agency, putting your agency at substantial risk. Without accurate payment, your agency may not have the resources required to provide a high level of care to patients. So that's directly from CMS. They're saying you guys need to rate this correctly so we can pay you correctly. It's I think a lot of times we sort of feel like Medicare is the bad guy, and they're kind of but they're really saying, listen, use these guidelines, accurately rate these people so that we can pay you enough to provide these patients with the right care. If we rate them incorrectly, then we run into situations where we're going, well, we don't know if we can see them for that many visits, or we don't know if we can provide them with the CNA that much. That's exactly what they're talking about. If we don't capture it, we won't have the means to provide them with the care we feel like is appropriate. So then this little handout here that I've given everybody describes in detail all of the Oasis conventions. I don't know if anybody has heard that term before. I hadn't, the Oasis conventions, but they're basically A good way to think of these conventions are, it's like CMS's way of sidestepping the dictionary. I mean, they give you these kind of rules of thumb that they expect we are taking into account when we're answering all of the Oasis questions. And a lot of them just really aren't straightforward at all. You would never assume this unless you knew these conventions. So it's important to have an understanding of that. And I'm not going to go through every single one of them during the presentation, but I want to go through a number of them that I feel like are pretty key to understand. So the first one is that understand the time period for each item. So unless they specify within the last 2 weeks or something like since the last start of care, resumption of care, it's assumed that we're rating the patient on the day of the assessment. To you, me, and every other clinician, on the day of the assessment means what we're seeing in front of us as we are assessing the patient. To CMS, per these conventions, the day of the assessment is defined as the 24 hours immediately preceding the home visit and the time spent by the clinician in the home. So that means if I'm in there at 9 o'clock in the morning and the patient was discharged from the hospital yesterday, I'm rating them based off of how they were in the hospital, for the most part. I mean, they may be a certain way when I see them, but that isn't the whole picture. That's not everything that I have to take into account. And the next convention goes on to kind of further that idea a little bit, that says if the patient's ability or status varies on the day of the assessment, which again is the 24 hours immediately preceding the home visit, report the patient's usual status, or what is true greater than 50% of the assessment time frame. So again, somebody's discharged from the hospital yesterday, we're seeing them in the morning. For greater than 50% of that 24-hour period, they've been in the hospital. So we rate them based off of how they are in the hospital. I mean, if we have notes that outline their functional ability and it seems very clear that they've just for whatever reason seen a dramatic improvement from yesterday to today, we still rate them based off of how they were yesterday. Next one here is as far as strategies and how we are supposed to rate them, it's a combination of a number of different things. Observation, interview, and other relevant strategies. It's acceptable to review hospital discharge summary to identify inpatient procedures and diagnosis at the start of care. So it's also acceptable to read their hospital discharge paperwork to determine their functional ability if we're running into that situation where they were just discharged yesterday. And the part I've highlighted here is it says direct observation is the preferred strategy. And for me, there's two takeaways from that. We do want to observe patients and not just go off of what they're telling us. But at the same time, we don't have to observe them doing every single thing. Direct observation is the preferred strategy. That doesn't mean we have to watch them take a bath or we have to watch them, manage their toilet hygiene. We can infer how they would do with those things based off of our observation of other similar functional tasks. This next one here to me is also a huge thing that we're missing all over the place. When an Oasis item refers to assistance, this means assistance from another person, and it's not limited to physical contact, and it can include verbal cues and or supervision. Examples of assistance include hands-on, contact guards, standby assistance, and even verbal cueing and reminders. That is to me, that's really where when we start talking about is somebody independent or not. Independent means there is absolutely no question in your mind when you watch them do something that you need to be near them, that you need to give them any kind of verbal cueing. If you even have to give them a reminder not to grab their walker to pull themselves up when they stand, that's a verbal cue. Regardless of how steady they look, you had to verbally cue them. They needed assistance. So I think of assistance as physical assistance. I tend to think of that when I'm rating a transfer. I rate how much physical assistance I give them. But it's not so somebody's getting up out of bed and you have to, cue them in how to get out of bed more effectively, or put your hand right here, grab your bed cane. Any of that is assistance. So consider that with any of these items that ask about whether a patient can do it independently. And we'll harp on that a little bit more here as we move forward. Another one here, rate the patient's physical and cognitive ability to perform a task. Don't rate on their preference or willingness. We're rating on their ability, but also their cognitive ability. If somebody doesn't possess the safety awareness to know they're doing something in an unsafe manner, even if we could correct that just by telling them not to do it that way, do it this other way, and their functional ability would allow them to do it that way safely, we're not capturing the intervention. You know, they cognitively on the day of the assessment, they lack the awareness of how to do it safely. I intervene and tell them, hey, don't do it that way, do it this way. Now they might be independent. But, you know, on the day of the assessment, they weren't. So again, consider that. Consider cognitive ability as well. Level of ability refers to assistance. We talked about that, I think. So, and another one here, the presence or absence of a caregiver may impact the way a patient carries out an activity. It does not impact the clinician's ability to assess the patient in order to determine and report the level of assistance the patient requires to complete a task. So if we feel like they're unsteady during gait, we rate them as a 2 or 3 depending on how much supervision they need. But just because they are going around throughout their day without anybody there doesn't mean they're independent. We feel they need supervision and assistance. That's how we rate them, regardless of whether or not they have it. And then understand what tasks are included in each item and select the response based only on the included tasks. That's, some of the tasks or some of the questions specifically include certain tasks, and we're only supposed to be rating them on those tasks that are specified. If the patient's ability varies between different tasks on a multitask item, report what's true in the majority of the included tasks and give more weight to the tasks that are performed more frequently. So to me, the biggest example of this would be the grooming question includes clipping their fingernails, includes washing their face and hands. If they were to leave their fingernail clippers on the nightstand next to them, that person may be able to reach over, grab their fingernail clippers, and trim their nails without any problems. But getting up and going to the sink to wash their hands is going to presumably require them to put their assistive device off to the side, have to stand there unsupported. It's significantly more involved than the task of clipping their fingernails. It's also something they're probably doing 2 or 3 times a day where, who knows how often they're clipping their fingernails, but it's probably not 2 or 3 times a day. I think we could all probably attest to that, right? So we have to really give more consideration to the washing their hands and how they would do with that. Here's another one for me, again, it's kind of an eye-opening moment. Consider medical restrictions when determining ability. If a physician has ordered activity restrictions, consider this when determining your response related to ambulation, transferring, and bathing. Okay. So take a patient who either got discharged yesterday, or let's just say they're a total knee replacement patient who has just been told they can't bathe for 7 days, and we come in and see them on day 5, and they are walking around just fine. They are getting up and down the stairs. They even show you that they can like hop back and forth on one foot. You're going, there's no problem with this person getting in and out of the tub. They still cannot safely participate in bathing. If we look at how we would rate them, we can't say just because they can get in the tub, they can do it safely with a grab bar or with a shower chair. They are completely unable to participate in bathing right now because they have a physician's restriction from telling them they can't do it. And the reason isn't that they're unsafe because they're going to fall. The concern is infection or the dressing is going to come off. Right. Regardless of what it is, we have to consider that. They may, if we see them on day 6, and let's put it this way: if we see them on day 7 now, right, and we're supposed to rate their ability for the majority of the time during the past 24 hours, and it's day 7, so their physician said on day 7 you can hop in the shower, no problem, and that patient has no functional restrictions. Now their activity restriction has been lifted. That you get there at 8 o'clock or 9 in the morning, and they've said, I got a shower this morning, it felt great, it was amazing, I had no problems, didn't need to sit on the shower chair at all. Still, for the majority of the time during the past 24 hours, they've had that medical restriction, so they've been completely unable to participate in bathing safely, at least. So they're a 4, 5, or a 6 on that question, depending on how, probably a 4, but you wouldn't really consider that. You're seeing a person in front of you who has no restrictions now, today, and no functional restrictions, but for the majority of the time in the past 24 hours, they had a physician's order saying they couldn't bathe. That's how we're supposed to rate them. And that's probably a hypothetical stretch of a situation, right? That person may not even qualify for home care at that point, but that's kind of how we need to be thinking. And these the ADL, IDL questions are, I don't think that they really are as much of a role in determining payment, but they're huge in determining our 5-star rating. which is, so there's two different 5-star ratings. There's a patient survey star rating, and then there's a quality of patient care star rating. And we have gotten to the point, we've been saying this for a while, where, you know, if our rating doesn't improve, we're not going to be able to get referrals. Our marketers are saying that now. They're saying they go into hospitals, and a lot of hospitals are saying we only refer to 5-star agencies, which they're really not supposed to do. It's supposed to be a patient's decision, but the patient doesn't know how convoluted and largely, you know, silly in some ways that this rating system is. They just see, you know, 2.5 stars, that's not good, or, you know, obviously you're going to go with 5-star, why wouldn't you? And we're at that point now where we're getting limited in our ability to get referrals, just probably because we're not rating these people correctly. I don't think it's that we're, you know, a crappy agency. So anyway, to expand a little bit on what the patient care star rating is, there's 9 questions that determine our 5-star rating here, and those are on, I believe, the next slide. There's 3 process measures: timely initiation of care, drug education on all medications, flu vaccine received, and the current season. Those are yes or no. If we met the criteria, we get a yes. If we didn't, we get a no. And then the outcome measures you can see listed here: ambulation, bed transfers, bathing, pain, shortness of breath, and hospitalization. To me, what I see this as, it's interesting to note, I should say, that a lot of these things are functional measures, you know, the outcome measures here, which aren't necessarily going to capture a lot of what nurses do, necessarily. Your focus is probably not purely on ambulation. You probably don't have a goal purely around bed transfers or bathing. You know, we can obviously argue the kind of treatments you're providing help with those things, but you can't look at a start of care assessment, nurses I think probably still are doing the majority of the opens, and say, well, ambulation, that's not what I do, I don't need to worry about it. I mean, it's a huge, it's a huge factor here. So these next slides here that say, how do we match up? Obviously didn't print out, but if you were to go to Medicare's Home Health Compare website, you could easily pull up you can just look up our company and you'll see our 5-star and patient care survey ratings. And it's not good. We're a 2.5 star company right now on our patient care rating, which again is really, to me, why this is important, that we understand what we're doing, you know, how we're rating them. So so I'm going to go into each one of these here. And we've been, I know, sending out little weekly Oasis guidelines. So some of these may be review at this point, but it's again, good to go over them. Every time I go through the manual, which I just never even thought I would be saying that I do that on a fairly regular basis, but every time I go through it, it's something else jumps out at me that I'm going, whoa, I wasn't even considering that, or I was doing this wrong the whole time. So the timely initiation of care gets based off of whether or not we saw them on the physician-ordered start of care or within 48 hours of the referral. And let's see here. So the pieces that this description that I've highlighted here are in order for it to be the physician-ordered start of care, the physician has to give a specific date. If we run into that situation where we call the patient, we obviously want to get out as quick as possible, they just won't let us, you know, we've made every attempt that we can, we've called their family, they're just not letting us in the home. It's really crucially important we call a physician back and let them know and say, hey, I tried my best to get out there Friday, they're just not letting me out, I'm going to come out Monday. If we get that order from the physician, now we can document that the physician's ordered start of care date is now Monday. So if we don't get that order, we're out of compliance with that time initiation of care. If we get an updated physician's order, we can use that as the start of care date. And that's what we should put in that Oasis question for that date, is we got a new order for the new date, we're going to enter the start of care date as the new one based off the order we got. The other piece of this here that I think is important, probably more important for intake, but good for us to understand as the clinicians as well, is that if there's no specified start of care date, the date of the referral, or rather the referral is considered to have been received when we've received adequate information about the patient, diagnosis and or general home care needs, and ensured that the referring physician or another physician has provided ongoing orders. So when we get an order on Monday,